Good evening. Today we shall be dealing with ECG case number 12 in our ECG series. The title is How to Analyze STEMI ECGs. If you like these videos, please like, share and subscribe, comment if possible, and press the bell icon to get notified when a new video uploads. This is a 45-year-old male who is having chest pain of 4 hours duration. Now let's imagine that you have not seen the patient, the nurse brings you the ECG, and let's see what information you can get from this given ECG. If you require further time, please press the pause button or you can go ahead with the video. Now, most of the time, most of the doctors, especially young doctors, just write the diagnosis of CAD anterior wall MI and then refer the patient to a nearby cardiologist or to a cardiac center. Now, is there more information that you can get from this ECG? What is this information that this ECG hides? So this is the diagnosis. It's a CAD anterior wall MI. There's no prizes to be given for this diagnosis because it's so obvious. Let's evaluate this ECG in the following headings: diagnosis, pathophysiology, site of lesion, prognosis, likely clinical status, and management. So let's look at the diagnosis. It's relatively simple. It's a case of CAD, ACS, STEMI, anterior wall MI. That means the coronary artery disease. It has gone in for an acute coronary syndrome. The type of acute coronary syndrome is an ST elevation MI. What is the MI? It's an anterior wall MI. So CAD, ACS, STEMI, anterior wall MI. Now some people may call this as an anterolateral wall MI because of ST elevation 1 and AVL. That's fine. Some people call this an extensive anterior wall MI. That is also fine. Irrespective of it, there's an umbrella term. An anterior wall MI gives you pretty much the right diagnosis. So there's a CAD, ACS, STEMI, and anterior wall MI. Now, what is the pathophysiology? It is an acute total occlusion of an artery by a red thrombus. Now, STEMIs are due to acute total occlusion of a single artery, 99.99% just one artery. So an acute total occlusion of a single artery by a red thrombus. That means it's a fibrin-rich thrombus. And a fibrin-rich thrombus responds to fibrinolytics like streptokinase or tenecteplase. So what is the pathophysiology? It's an acute total occlusion of an artery by a red thrombus. What is the pathophysiology of NSTEMI? It's critical narrowing of one or more arteries by a white thrombus. So you can have multiple arterial occlusion narrowing in case of NSTEMI, which is usually critical. By meaning critical, it's more than 70%, and it's due to a white thrombus. White thrombus are platelet-rich thrombus, and for that you give antiplatelets. What is the site of lesion? Since there is ST elevation in the anterior leads, it's an anterior wall MI, which is due to occlusion of the left anterior descending or LAD. Where is the site? It's a proximal LAD. So when you get, there's a dictum, when you get ST elevation in the anterior leads, look at the inferior leads to localize. So whenever you get ST elevation in the anterior leads, look at the inferior leads. If you see ST depression, it signifies proximal LAD. If you see ST elevation, it signifies a wraparound LAD. Now, wraparound LAD is an LAD which goes and supplies the apex, continues beyond the apex, wraps around the inferior wall and supplies the inferior wall. So, ST elevation in the inferior lead signifies a wraparound LAD. If you get a flat ST segment in the inferior leads, it signifies a distal LAD. Now, here you can see ST elevation in the anterior leads. We are looking at the inferior leads as an ST depression. So it signifies a proximal LAD. Now, there are other markers to localize to a proximal LAD, but that is a topic for another video. Site of lesion is a proximal LAD. Why is proximal LAD lesion so important? It supplies a huge amount of myocardium. So these patients are likely to go in for LV dysfunction and cardiac failure. Supplies the conducting system. Now the LAD along with the right coronary artery supplies most of the conducting system of the heart. So if there's an occlusion, you can go in for heart blocks. It supplies the intraventricular septum. So these are your three reasons why the proximal LAD lesion is so significant. What is the prognosis? Now, if you have a look at the ECG at V4, V5, and V6, you can see that there is no real descending limb of the R wave. The descending limb of the R wave is obliterated by the ST segment. Now, this pattern has been described by various people as a shark fin pattern, as a tombstone pattern, or as an action potentialization of the ECG. You can see that the ECG mimics the action potential, especially in V4, V5. So the three descriptive terms are shark fin pattern, tombstone pattern, or action potentialization of the ECG. Whenever there is no descending limb of the QRS complex or the QRS complex is distorted by the ST segment, this signifies that the Purkinje fibers are involved, and the Purkinje fibers are your most resistant area of myocardium to ischemia. So involvement of this signifies extensive damage to the conducting system of the heart. You expect LV dysfunction and a bad outcome for such a patient. This is the patients whom you prepare the family, because these patients often don't respond well to PCIs or thrombolytics. So this is described by Birnbaum et al. Again, you have another Birnbaum sign in inferior wall MI. So grade 1 ischemia is peak T waves. So you can see grade 1 ischemia, this is a hyperacute T wave. Grade 2 is ST elevation without QRS distortion. So you can see the QRS segment is preserved and the ST segment is elevated. Grade 3 is ST elevation with distortion of the terminal QRS complex. This is when there is the descending limb of the R wave gets started to get obliterated. And so there's a distortion of the QRS complex. So this is grade 3 ischemia. The importance is the Purkinje fiber is involved. The Purkinje fibers are a most resistant area to ischemia, and involvement of it suggests a bad prognosis. This is a study which came in the European Heart Journal. Grade 3 ischemia is significantly associated with a larger infarct size, impaired myocardial salvage. That is, it responds poorer to primary PCI or thrombolytics. And if you are able to establish flow, there is a significant reperfusion injury. So it is independently associated with major adverse cardiac outcomes. So grade 3 ischemia is bad. So all of this, a huge area of myocardial matrix due to a proximality lesion, along with the grade 3 ischemia, signifies a bad prognosis. You see the CCG, you start preparing the family for a worse outcome. So diagnosis, we have covered pathophysiology, site of lesion, and prognosis. What is the likely clinical status? You can see this tachycardia on the ECG. The heart rate is around 100 to 120. This signifies that the patient is going in for heart failure or is probably in heart failure. Again, this is just a clue. If you see tachycardia in anterior wall MI, especially at fast heart rates, you think that this patient is gone in for heart failure or will go in for heart failure. This is especially supported if you have a left atrial enlargement on an ECG. Again, we're not seeing that clearly in this ECG. Again, left atrial enlargement will signify that the LA pressures are higher and the patient is likely to go in for pulmonary edema. So you expect this patient to go in for heart failure because of the site of occlusion, the degree of ischemia, and the tachycardia you see on the ECG. The management is pretty obvious. It is primary PCI, which is more preferred than thrombolysis. Again, you expect incomplete recovery of this patient, so and a worse outcome. So diagnosis: CAD, ACS, STEMI, and anterior wall MI. Pathophysiology: acute total occlusion by a red thrombus. Where is it occluded? It's a proximal LAD. What is the prognosis? It is bad because the proximal LAD is involved. There's a grade 3 ischemia. You expect the prognosis to be bad. What is the likely clinical status? The patient is in heart failure or is going in for heart failure. What is the management? It is primary PCI, which is better than thrombolysis. So instead of writing the diagnosis of CAD, anterior wall MI, and referring this patient, you can get a lot of information from the ECG. The ECG hides a lot of information and it is only available for the trained eye. So take home points: ECG is the single most important test in medicine because no investigation in medicine can give you as much information as the humble ECG. ECG gives you much more information than merely a diagnosis. Try to gain a lot of information from the ECG, the pathophysiology, the treatment which can be offered, possible complications of a disease. So try to get the maximum information you can from an ECG. ECGs are learned over a lifetime. The same ECG is can be seen by an MBBS person, can be seen by an MD person, can be seen by a DM person, can be seen by a person who's done an electrophysiology fellowship, and all of them get different information. So ECGs are learned over a lifetime. You cannot master ECG by reading an ECG book. You need to see patients, you need to see repeated ECGs and learn it over a lifetime. A close examination of ECG is rewarding for both doctor and patient. If you are able to have a mastery of ECG, it is most often you will save a life. So try to read about ECGs, try to learn about ECGs, and you and your patient both will be rewarded. If you like this video, please like, share, and subscribe, and press the bell icon to get notified when a new video uploads. Thank you.